Hello to all. Today, Tuesday, I think 11th of May, correctly, to another webinar. Today we speak about advanced diagnostic tests and personalized treatment. My name is Dr. Christos Roukoudis. I'm a gynecologist and fertility specialist at IVF-Spain. And today I will share with you my thoughts, our thoughts regarding this topic, how we can do things different than others, and also that's one reason for our success, your success and our success. Okay, I think let's wait another minute so that everybody can still log in. Like always, you can write your questions down in the Q&A area, and in the end I will try my best to answer all of them. And if for some reason I will not be capable to answer all of them, then I promise that we will do our best to answer the questions tomorrow. Okay, then let's start. With the progress of reproductive medicine, it is possible for us to offer a treatment that relates precisely to the problem at hand, because each patient case is unique, therefore individual treatment is required. The keyword is person-related diagnostic and treatment. Before proceeding to a transfer, to a therapy, to a stimulation, it's crucial to determine the causes of infertility, miscarriages in the past, and the solution before starting any treatment. That's something that is extremely important. It's not about repeating the same thing. The maturation of vitrification, meaning the process of freezing and thawing, allow us to take all the time necessary for diagnostics until the perfect conditions for a transfer are present. For example, if we are in terms of increasing the success after several miscarriages. There are various reasons why a treatment is not successful. Therefore, it's even more important to find out where pathologies are present. The advanced diagnostic must attend for sure equality to the endometrium, male factor, and other causes. Without a doubt, the most important thing is the egg quality, and in addition, with the endometrium, those factors are the most important factors. Let's attend to say a few things more about the egg quality and the ovarian reserve in general. Before starting a treatment, the egg reserve should always be determined. The parameters that are taken into account are age, mother's age, AMH, and follicle count. The iron rule should always be determined beforehand to give the couple realistic chances for a possible treatment. Shared decision-making is something that I say to my patients because it's crucial for treatment on equal footing. Let's say we have diminished ovarian reserve. Together with a couple, we speak about the options. Very often, I see patients that come to us after several attempts, and especially from countries where testing of the embryos is not allowed. And those couples have the woman, for example, AMH 0 something, 0,01, and they did simulation cycle after stimulation cycle without telling to that couple that the possibility of success is equal to 0. So here it's very important to be transparent, to speak about the condition, about the ovarian reserve, and then together speak about the additional treatment, the options that are available. Coming back to the topic of ovarian reserve, evaluation and expectation, the anti-Malarial hormone. For sure, you heard about the anti-Malarial hormone. With increasing age, the population of oocytes shrinks, which is reflected in a decreasing AMH. AMH, or anti-Malarial hormone, is a substance produced by granulosa cells in the ovarian follicles, and it's an indicator of how many follicles are still in the ovary. How many, to be more precise, how many eggs are inside the follicles in the ovaries. Generally speaking, the recruitment of eggs in each gynecological cycle is an inefficient process. Think of it as a race in which 20 sprinters compete, but only one eventually reaches the finish line. It's the same during the oocyte maturation in each cycle. Several follicles are recruited, but only one dominant is created and release it eggs at ovulation. The rest do not make it and become atretic and part of the ovarian stroma. The second problem with the oocytes is that with advancing age, the quality of the oocytes also suffers. We know all women are born with a pool of eggs at birth. Those eggs, therefore, have the same age with a woman and accumulate damage in the genetical material. So we have a problem in quantity and quality. One of my favorite studies is the study from the group around Mr. Atta. Almost 60,000 blastocyst day 5 embryos were tested, and we saw that when a woman is 20 years old, almost 80% of the embryos that she produced, blastocysts, day 5 embryos, are healthy with the proper amount of chromosomes. When a woman is 35, 50% of the blastocysts are healthy. When a woman is 40, less than 20%. When a woman is over 43, less than 10%. When a woman is, 40, around 20%. So you can see exactly what does it mean that here in the graphic that the rate, for example, for Down syndrome or other abnormalities in the number of chromosomes are increasing with increasing age, with advanced reproductive age. So what's the solution in this case? Let's say we have a woman. She is over 35. So we know that from the statistics that the possibility that the embryos that she produces are at 50% good, have the normal amount of chromosomes. What should we do? First, as I said, we estimate the ovarian reserve. Second one is we do a priming. We try to increase the quality of the eggs with hormones like DHEA, like growth hormone. Then it's very crucial especially, as I said, in advanced maternal age over 35, to do a pre-implantation genetical testing on the embryos to see if numeric abnormalities are there. That means if the number of chromosomes are not properly, and we can see also if some mutations are there. Then, personalized stimulation protocol. We learn from every previous cycle. So always I ask for the protocols from the treatments before. In general, you don't give the same stimulation protocol to every woman. Age is important, as I mentioned, and the response is different. If I compare a woman with 35 to a woman with 49, 48. So it's very important. Then ovarian rejuvenation could be also an option if the ovarian reserve is diminished, because especially in a setting of embryo banking where I accumulate embryos, I try to get as many embryos as possible. Ovarian rejuvenation could be an approach, because then will be capable to produce more follicles, gain more eggs, fertilize more eggs, and in the end have more embryos to analyze them and look which of them are healthy to have enough for a transfer, and so to increase the success. And also to decide if IVF cycle makes sense or we should shift to ectonation. This is something that will follow this decision making after, as I said, after I estimated your ovarian reserve. Now, let's go to the endometrium. Another extremely important factor, as I said, is the endometrial condition. The lining thickness, very important, should be, if possible, above 8 millimeters. We should not concentrate on dogmas. 8 millimeter, it's okay, it's important, but also how it appears during the scan. When I see that 3 lines are there, okay, I would be satisfied even with a little less. But if not, we have a certain step-up protocol how we address this matter. Especially women with Asherman syndrome, for example, they belong in this category. And another approach in this case would be to inject, to do regenerative medicine in the lining, like PRP. Then the uterine anatomy, also very important, like myomas can cause us trouble, or a septum. Careful consideration is given to whether a transfer makes sense in this case under those conditions, or whether surgical rehabilitation would be preferable, especially if several abortions have several miscarriages have already taken place. Here is also very helpful a new diagnostic tool that we have, the office hysteroscopy. We perform it on the gynecological stair without any, it's unnecessary that we have it under anesthesia, and we can take a look and see, for example, if a myoma has a bad impact to the cavity. And also, another advantage is that the couple can see on the screen the problem at hand, and everything is explained in detail in the live picture. Now then, the endometrial receptivity, endometrium immunological test, ERMAP, EMAP. I will say something about it with the next slides. Then screening from chronic endometritis. This could be also a reason for recurrent miscarriages. So a screening, if I see a woman with several miscarriages in the past, I screen, I test the lining if she has chronic endometritis. Endometrium culture, also very important to see see exactly if the conditions are there to let the embryo develop. Regarding the ERMA, it is known that during the first half of the gynecological cycle, the follicles grow, produce more and more estrogen, which make the endometrium grow. Ovulation occurs from the dominant follicle. The follicle that remains then in the ovary becomes a corpus luteum, the yellow body, and produces progesterone, which causes the endometrium to become more compact and vascular. Studies have shown that roughly 70% of women find that 5.5 days after progesterone produce is the best time for the embryo to implant. However, 30% of the women need either 1 day more or less progesterone. This, whether you are one of those women, we can find it out through a biopsy. And that's exactly what this ERMAP test is. And we perform it after endometrial preparation with estrogens and progesterone. And the testing is done on the gynecological chair using a small endometrial sample. In general, in principle, the gynecological cycle is mimicked with estrogens and progesterone after the central control while the pituitary gland is suspended. Also, this would be very important when, for example, you had several attempts without any positive pregnancy test. This could be the reason. Next, the EMAP test. Pregnancy is an exceptional process in which the woman's immune system is not only able to adapt its functions to tolerate the development of the embryo, but also participates actively in the implantation and the evolution of a pregnancy. You must think pregnancy is kind of a transplantation. There is foreign material for the woman's immune system who try to implant in the uterus. So to achieve a successful gestation, it's essential that maternal and fetal cells coexist in a finely regulated immune balance. And recent studies have shown that alteration in this balance could lead to the appearance of complication during the pregnancy. With this EMAP test, we are capable to see if the immune system of the mother is worked properly, and this allows us to investigate what's the reason for the miscarriages. As I said also before, that's a test, very important, especially if you have experienced a miscarriage or several miscarriages. Now let's go to our part, to the male part. Also very important, the male factor, because you can see it here on the screen. 40% of the infertility cases are due to a male factor. The World Health Organization criteria are very straightforward. Important is that the volume of the sperm sample is above 1.5 millions. The concentration should be more than 50 millions. The motility should be at least 30%, and the morphology should be also at least 4%. We have the several diagnostic tools. We take a look after the DNA fragmentation. If the DNA fragmentation is high, you can see here our protocol. We give vitamins, supplements, antioxidants, and look if we have an increase in quality. In general, the seminogram, the spermiogram has, you can see big differences from spermiogram to spermiogram. So we give it a try, and if nothing helps, we have also other diagnostic tools like apoptosis detection, like TESA, to take a sample directly from the intestinals, and then to use other fertilization techniques like IMSI and PICS. Now, we have also other causes for unsuccessful attempts, and some things that should be standard is, for example, a karyotype. Karyotype is very important, especially if many miscarriages occurred so far. We recommend to perform before stimulation. I do that always before starting a stimulation. This test can determine if a numeric or structural anomaly of the chromosome is present, and may be the reason for producing unhealthy egg cells or sperms. It can be the case that you are look for normally, but if I take a look after your chromosomes, some alterations are there, like for example, a translocation. This could be not have an effect on your appearance, but it can be the case that the eggs that you produce or the sperms that you produce are not healthy. They're not healthy, and it would result in unhealthy embryos. Then thrombophilia, to screen if, for example, a factor V mutation there. We know the factor V mutation is strongly related with miscarriages. If it's the case, we can treat that with additional medicaments. The thyroid must be working properly. I want a TSH below 2. I don't want to have high antibodies, thyroid antibodies, because also this could be a reason for not implanting the embryo, and or for a reason for miscarriages. Autoimmune diseases like the antiphospholipid syndrome could be a reason. We screen for them. We screen if several other antibodies are present, like ANA, like asthma, or factor antirheumático. And also other immunological tests like the KIR-HLA-C genotyping, an adequate immune interaction between both embryo and mother to allow the implant is necessary. As I said before, the maternal immune tolerance towards the embryo is achieved through the interactions between the cells of the maternal immune system present in the uterus. The name is NK cells, natural killer cells, and the embryo. Those cells recognize the embryo through receptors located on its surface. That's the KIR, what you see on the screen, which attach to an embryo identification fragments found on its surface. That is the HLA-C complex. And one is inherited from the mother and another inherited from the father. Several studies have shown that certain combinations of KIR and HLA-C are more likely to lead to complications in pregnancy. And this genotyping, to find out exactly what type you have and what type your donor can produce, allows to determine whether there is a good compatibility between the uterine receptors and the foreign HLA-C presented by the embryo or not. If so, the process of maternal fetal tolerance will develop correctly and the pregnancy will evolve without complication. Otherwise, this compatibility between the embryonic HLA-C and uterine KIR receptors does not exist. The process of embryonic acceptance, and so the pregnancy will be compromised. So if we do that, it allows us to identify the cause first of recurrent miscarriages and implantation failures. Decide the optimal number of embryos to transfer, very important, because if such irregularity is there and I transfer more than one embryo, then the possibility that a miscarriage or implantation failure occur is higher. Also, you prevent possible complications during pregnancy. We start with a medication plan after you stay pregnant, and also we can choose a compatible donor if we know that your karyotype for their future pregnant woman in both oocyte and sperm donation cases. This test is performed on the couple's DNA. For this, around 4 or 5 milliliters of blood from each member of the couple is required. And in case of oocyte or sperm donation, donor HLC genotyping is required. So, regarding the personalized follow-up, with our patients on every steps until the end of the first trimester, in the stage of ovarian stimulation and transfer preparation, the medication type, dosage, states, all of them will get personalized according to the results of the diagnostic test cycles before. During that embryo transfer, we check always your progesterone level. Is your progesterone too high? Maybe you'll postpone the transfer. We do scans to estimate that your lining is perfect to do the transfer. Also, with a scan, we are certain that during the transfer that we place the embryo exactly there where it should be. With the ERMAP, we can find the perfect timing to do the transfer. As I said, the lining must be as thick as we wanted to have it. If not, we have the step-up protocol to work with your lining. Then after the transfer, we, according to your progesterone level, we support your progesterone levels with external income of progesterone. The EMAP test that we have performed before will tell us if it's necessary to give you still some immune modulators or antibiotics. And also, depending on your medical history, we will proceed. So, the key message is that our contact from the moment that you are interested to have treatment with us, we try to find everything from your treatments in your past. We try and do our best to adjust to it, and then we proceed until the transfer of the embryos and after that. You see again our locations here in Europe. All of our clinics benefit from our experience, and we have the same protocols regarding the treatment, regarding how we proceed in each case. And here you see our email address. So if you have any questions, anything, if you want to share your case with us, to give you some thoughts about it, what we have done different, what we suggest, please contact us for a free consultation to speak about your case. And now let's answer all of your questions. Mrs. S asked why in some countries testing of embryos is not allowed. It's difficult to to answer this question, there are many reasons. There, for example, religious beliefs, for example, ideologic beliefs are an obstacle for testing the embryos. So it's different from country to country. That's true. Religious beliefs are a big obstacle. Mrs. M asked, what test do you recommend for screening for chronic endometritis? I would suggest to do culture from endometrium, also to do screening for CD138. This is a receptor on the surface of some cells. If the cells are present, then it's a strong indicator for chronic endometritis. What IVF protocols do you have for patients with polycystic ovarian syndrome? We try, in this case, to do a stimulation not as in doses not as high as normally, but also it's not like we do the same exactly stimulation protocol in this case. You must see a little bit your hormone, all of your hormones to estimate which the best dosage and how exactly to proceed. So I think the best is to send us some more information in an email, contact at IVF-Spain, and then I can. I'm glad to tell you more details. Mrs. M asked if the embryos must be on day 5 to be tested for genetic problems, at least to do PGTA testing, because those embryos have more than 150 to 200 cells, and the survival rate after a biopsy is more than 98%. So yes. Mrs. H asked, what are the treatment protocols for low sperm morphology, less than 1%? We will try with the supplements and everything, but most likely Ateza will be necessary. Mrs. S. I'm freezing my eggs only. Right now, I am 34 and 5 months. How many eggs do I need to freeze for 3 babies? From my knowledge, on average, each extraction pool 8 to 15 eggs. We know that the things that you must take in account is that almost 50% of the embryos, the blastocysts that you produce, are healthy. Okay, have the proper amount of chromosomes. So this is one thing. The other thing is that during stimulation and fertilization of those eggs, or around 30% of them will reach day 5. That's the other thing. Also, thawing your embryos, thawing your cells, you will lose roughly 30%. For all those reasons, I would recommend you to do at least 2 to 3 cycles. Mrs. S asked me if IVF is possible on a hypoplastic infantile uterus. What is the treatment protocol in this case? This is a difficult answer to give you now something that is 100% the truth. The best thing is I need to see some pictures, some scans, to see exactly how your uterus is, and then let's stay in touch, and I can tell you my opinion about it. Mrs. S. Poor response to first round of IVF, egg selection cancel. Would you suggest egg donation? I need some additional information. For example, as I said in the during the webinar, your egg reserve, the AMH, the antral follicle count. From your age, I know that around 20% of the embryos produced are healthy. So I need those information to give you a realistic answer. And also how many eggs how many follicles they saw, as I said. Mrs. B asked me, hello, I have 7 frozen blastocysts not tested, and I'm waiting for karyotype results. Should this blood test give me an insight about my blastos? Should the results be correlative to the embryo quality? Normally, you proceed the opposite way. You do first the karyotype, and then you do an IVF cycle. Sorry. You did it, fine. Let's see the results. You should react only if it's, it's something black or white. Give you, for example, if you see that some serious alteration in your karyotype, that means that you produce only unhealthy embryos, okay, then you should think about not to transfer those blastocysts. But I strongly doubt that's the case, because we have 7 blastocysts is a very good outcome. Something that would be even better is to do a PGTA test on them, and then you have exactly information about the blastocysts and can transfer the first one. Mrs. S asked me, let me see the question from, then at the point of IVF, when I have a partner, each IVF cycle will take how many eggs and how many cycles it takes to be successful. I need some additional information about your egg reserve. For example, if you have AMH of 0,2, then it will be a different outcome if you have, for example, AMH of 2 or 3. So I need this information. But I think the best thing is to send us your medical history on contact at IVF-Spain, and then let's schedule free Skype, and I can give you my opinion about it. Mrs. M asked that if we do hysteroscopies. Yes, of course. And also, if we do this office hysteroscopy, it's even easier to perform, and also without anesthesia. Mrs. H, I don't exactly understand your question. You wrote that what do you recommend for a partner? No reason for infertility more than 3 years on IVF failure. Okay, now I caught it. As I said before, if you remember what I said about all the necessary tests to be done, also, in your case, Mrs. H, I think the best thing is to contact us, to send me your data for a free Skype or a free consultation, and let me take a look what have been done so far to give you precise information. Mrs. M asked, would you plant more than 1 embryo at a time? We here in IVF-Spain transfer embryos on day 5, because day 5 is a quality criterion. The development from day 3 to day 5 is a quality criterion. So I don't want to miss it. And then, regardless if I transfer 1 or 2 blastocysts, the success rate is not increasing so much. It's more an obstacle for one healthy embryo, and also the reason for the possibility for a twin pregnancy is very high, with all the risks that are there. And I was a long time a consultant, and I worked so many years and also in obstetrics, so I know exactly that a twin pregnancy brings severe risks. So we prefer to transfer only 1 embryo. But if we have a couple here with a strong wish for a twin pregnancy, we take a look in the medical history, speak with a couple, and if still the wish is there, in some cases we transfer also 2 embryos. Then the next question is from Mrs. V. Do you freeze embryos at day 3 or day 5? You freeze embryos on day 5 because then we have blastocysts and not morula, that's in day 3. And those day 5 embryos are so strong, the thawing process is like it's nothing for them, and the survival rate is over 98, 99%. Also with our advanced techniques here in IVF-Spain. Mr. W asked, is a 6-cell embryo okay to implant? You can't do that. The thing is that first, you don't know exactly what you transfer. You don't have this advance in evolution from day 3 to day 5, because normally only the strongest embryo survive until day 5. So if you transfer an embryo on day 6, you don't know exactly what you transfer, and the risk for an unsuccessful attempt is extremely high. And that's also the reason why some centers transfer 3-4 embryos, because they hope that at least one should develop. But it's not effective work. It's like playing lottery. Mrs. B asked about the relation pregnancy and fibroids. What would be my advice? Look, not every fibroid is the same. Some fibroids are subserous, are direct under the serosa, the outer layer of the womb. Normally, those are not a problem for a pregnancy, for a successful implanting pregnancy, and also not a reason for miscarriages. So in this case, I don't recommend to remove those fibers. Now, if you have a fibroid that is big and has an impact on the lining, then yes, it could be an obstacle for an implant and also the cause for miscarriages. In this case, maybe it's a good idea to remove it before doing a transfer. Also, in this case, it's important that I see how exactly the fibroids are. Send me a scan, send me some pictures, or I would prefer to perform the scan myself to tell you my opinion about it, if it's a good idea to attend first the fibroids and then do a transfer. Then, but good question. Other than genetic testing, do you have any advanced technologies, cameras to assist in the selection of the most healthy embryos? Yes, I do. Yes, we have. Like time-lapse is a very thrilling technology. It allows us to have many pictures each day from the development of your embryos, and especially if you don't perform a PGT-A test, it helps us to select the best suitable embryo for transfer. Okay, I'm 37 years. I have performed 3 IVF, and the most number of eggs was 6, and maximum 4 embryos day 3, no pregnancy. This is a normal number of eggs for my age and IMH of 0.65. Thank you. 0.65, it's 0.65 in a nanogram. If it's in nanogram, it's a bit low, and also the outcome of your cycles is is what I would expect with an AMH of 0.65. We have here some new, we can perform, for example, regenerative medicine, where we can increase your AMH and also the number of follicles that you produce, because in your case, it's most, from what I see, it's more a problem of quantity, and because you are young, and most of the, at least 50% of the blastocysts that you produce are healthy. But it's a very interesting case. Please let me take a look the therapeutic protocols that you have, the stimulating protocols that you have, and everything, and to give you some more precise answers. Okay. Mrs. A asked, if you get ectonation IVF, are advanced diagnostic tests recommended? As I said in the beginning, for successful treatment, the most important factors are the embryo quality and also the endometrium. For example, let's say it's your first attempt and you do ectonation. I will take a look. I will only do the basic endometrial diagnostic. For example, to see your implantation window, when's the best time to do the transfer, and also to see from the immunological point of view if something is there. That's scenario number 1. Let's say the second scenario, you had several treatments before with your own eggs, and you have one miscarriage after another. In this case, I will do additional diagnostic. Mrs. Z asked, I'm almost 43 years old and did mini stimulation cycle, you mean short stimulation cycle, okay, which resulted in 4 eggs collected with 4 blasts, but all came back abnormal. My AMH is 0.5. Would you recommend to keep trying to find a genetic normal egg? Mrs. Z, the thing is that the possibility that we find blastocyst with a normal with normal chromosomes, so euploid blastocyst, is very low. It's less than 10%. We have also the problem of collecting enough eggs to fertilize them, because your AMH is also 0. So the fastest way to have a healthy children at home would be ectonation. There are also some approaches of generative medicine, like I said, and also I have a very interesting video, and I did a webinar 1 month ago. If you go on YouTube and type IVF-Spain and and Dr. Roukoudis, you can see it. PRP could be an approach, but I would recommend in your case, from the things that I saw so far, and also because you have a long journey behind you. And also, if you are at the point where you can close the book working with your own eggs, then ectonation would be the easiest way to have a children at home. Mrs. H asked if the egg collection process is under general anesthesia. Not always. It depends also from what you wish. Mrs. A, I was not suggested to do this karyotype because of my age 34. With one IVF, we produced 9 blasto out of 12 eggs. Very good. But after 2 already failed transfers, I decided on my own to do karyotype before tested them and risking to lose any. No, I would. If an embryo is not haploid, has not a proper amount of chromosomes, then it's not suitable for transfer. So do the test, exclude those embryos that are not healthy, and then you have only the healthy embryos to transfer, because the other embryos, they will result in a miscarriage or in an unhealthy embryo. Mrs. Z asked about some findings in the blood, and if it's possible to get pregnant. Please contact us, and I will tell you our treatment protocol. I don't have it here with me now, but I can say to you exactly which protocol. But yes, it is possible to get pregnant. Mrs. S, because regarding how you can send you my scans, contact my assistant via contact@ivf-Spain.com. Tell her to schedule a mini Skype, free Skype, and also send me all the documents that you have so that I can take a look and give you my opinion about it. Mrs. A asked me also something regarding abnormalities in the uterus. Would you do a surgery? If it's a T-shaped uterus, it depends a little bit how thick the septum is. It's exactly the same in your case. Please contact us. Let me see some the pictures, and I can tell you exactly what I would recommend, if it's possible to remove it or not. Mrs. A asked, but can I test the blastos also if they're already frozen? Yes, for sure, it's possible. It depends a little bit from the center, from the clinic that you are working. We have here a survival rate over 98%. So I would risk to lose maybe one, and know that they are healthy instead of transferring something that's not tested. It's my approach, and also something that I recommend, because also from your history so far, you had miscarriages. I would do that. Mr. H asked if gender selection is allowed now. No, it's not allowed in Spain at all. You're welcome. It was, like always, a pleasure. As I said, if you have any additional questions, please contact us, and let's speak about your individual case, and I will share our opinion about it. It's something that I say always to my patient. Knowledge is the power, and as more things you know, so better choices you can take into. I wish you a wonderful evening here from Alicante, and see you soon. Bye-bye.